Great. Welcome, everyone. It's right at 7 o'clock here in Ann Arbor, Michigan, and you're joining the Mind Matters educational series. We'll probably wait for another 3 to 4 minutes just to give people a chance to join, and then we'll go ahead and get started. While we're waiting, I can just give you a little bit of background. This educational series that we call Mind Matters is something that we developed about a year and a half ago with the goal of bridging the world of addiction research with some of the work that's done clinically here. As you may know, U of M has a robust research enterprise, and if you think across departments here at U of M, there's probably 40 or 50 different faculty members that do addiction that's either directly or indirectly, that's do research that's either directly or indirectly related to addiction. So it's something that happens a lot here, but I think historically we haven't done a great job of linking the research and clinical worlds. So our goal at the clinical program at U of M, which is called UMATS, is to build on research and make sure that it's really at the core of the care that we provide. But I think we haven't historically done a great job of explaining our rationale to patients and their families and the general community on topics like what is addiction treatment. And so the goal of this seminar series is to share some of this information and hopefully allow us and some of the people we serve to be more on the same page. So as I mentioned, this is relatively new for us. We have 4 presentations and we rotate through those, and we're really eager to get your feedback. We'd love to hear what information are we not presenting that you'd like to know, what is helpful, what isn't so helpful. And so there'll be opportunities at the end to share your feedback, and we'd really appreciate that. So we're getting close to a few minutes after 7, and people are still joining, but I think we can go ahead and get started. Let me welcome you to the Mind Matters educational series. This is the second of 4 presentations, and this is what we call Addiction Treatment 101. I'm Mark Ilgen. I'm a professor in the Department of Psychiatry and director of the University of Michigan Addiction Treatment Services, or what we call UMATS. UMATS is located in the Rachel Upjohn building off Plymouth Road in Ann Arbor and is part of the Addiction Center in the Department of Psychiatry. And as I mentioned, really a core of what we do is to deliver care that's informed by research. And what we're hoping to do tonight is give more of a background on some of the research underlying the care that we provide. For tonight's talk in particular, where we're talking about addiction treatment, we'll discuss what treatment options are out there, what type of evidence is there behind these different treatments, and how do we attempt to use these treatments in the real world. Tonight, joining us is Dr. Alex Weigard, who's an assistant professor in the Department of Psychiatry. And Dr. Weigard is a researcher and practicing clinical psychologist with us at UMATS. His area of expertise includes machine learning and use of new techniques to enhance real-world prediction of substance use disorders. Dr. Weigard received his doctoral degree in clinical psychology from Penn State with a special emphasis in cognitive and affective neuroscience, and he completed his postdoctoral fellowship here in Ann Arbor at the U of M Addiction Center. Dr. Weigard, thanks for joining us. Before we begin, I want to mention that questions can be submitted by clicking on the Q&A bottom function at the bottom of your screen. And there is an option to submit questions anonymously. After Dr. Weigard's discussion, we'll do our best to answer as many questions as we can. And for those of you who are used to using chat in Zoom, we really encourage you to use the Q&A function. I think that the chat function is actually not going to be turned on for this session, and instead you can submit the questions through Q&A. A recording will be available and emailed out to you as an attendee as soon as it's available. So now let's begin. Dr. Weingart.
All right. Thanks very much for the introduction, Dr. Ilgen. And thank you everyone for attending tonight. I'm really excited to talk about addiction treatment and therapy with a special emphasis, at least in this part of the series, on behavioral treatments for addiction. And then some information about what somebody can expect if they're seeking out addiction treatment and what we offer here at the University of Michigan specifically. So just to first provide an initial roadmap of today's talk, so we have a number of different learning objectives. So one of them is that I'm going to start off by reviewing the broad history of addiction treatment and scientific research on addiction that has informed those treatments. So basically, how did we get here? And then I'm going to provide an overview of current evidence-based behavioral addictions treatments that are generally used in practice. Then I'm going to outline some facts about how treatment recommendations are made, what a patient can actually expect if they're seeking out treatment. Then I'm going to answer some frequently asked questions that you might have. And then we're going to start a discussion where we basically, Dr. Ilgen and I are going to talk about some questions that the group has and some other issues. And hopefully we think that this can be informative and that you get something from this. So the first thing I'm going to talk about is the history of addiction models and treatment. I'm going to focus specifically on the 20th century because this is where a lot of the details of addiction treatment started to come together and evolve. So it's important to acknowledge that addiction research and treatment have both largely been driven by the prevailing societal understanding of addiction, which has changed substantially over time in many different societies, including our own. So in the early 1900s, it's really much, and for really actually much of the history before that time, what we could call the moral model of addiction prevailed. So people with addiction were generally seen as sinners with a moral weakness, and treatment was really inhumane and unethical by today's standards. So people were typically ostracized from society rather than any attempt to help or to cure them of their addiction. And this showed up in many ways. One of the most kind of darkest parts of our history is that in the early 1900s, there were actually several waves of state laws that were passed that were calling for the mandatory sterilization of what they called defectives. So this included people who were mentally ill, developmentally or intellectually disabled, and it also included people with addiction. So this was really a kind of a dark part in our history where we weren't really focused so much on helping people and more kind of viewing this as a moral failing. So this started to change in the early 1900s. So about prior to this time, it's actually worth noting that a lot of drugs like opioids, cocaine, and alcohol were actually not regulated at all by the government. And in fact, they were also available in a lot of common over-the-counter medications that made various claims, often pretty dubious claims, about their ability to treat different ailments. This changed in 1914 when the government put physicians in charge of prescriptions for a lot of narcotics. And it also began to tightly control access to drugs and alcohol. Of course, in the 1920s, the government began a decade-long experiment in prohibition of alcohol. It actually was the result of a constitutional amendment banning the sale of alcohol. And as you might guess, this had a really profound effect on society. It ended up being a pretty unpopular law, and it was repealed in 1933. And then later in the 1930s, the federal government began to get involved in addiction research and treatment. They started to view this not necessarily as a moral failing, but as a social problem that it might be amenable to intervention. So in part as a reaction to the prevailing moral model of addiction, the enactment and repeal of prohibition, and then changing trends in American society, Alcoholics Anonymous was formed around this time. So it was developed by two men, Bill W. and Dr. Bob, in 1935, and they started to hone their ideas into a number of writings in the late 1930s. And AA really started to grow to prominence. The reason for this is that there was clearly a void for addiction treatment at the time that needed to be filled. AA was really the first attempt to move beyond this conceptualization of addiction as a moral failing and actually move towards a model where we'd actually treat people and help people overcome addiction. So the general model of AA is that addiction can be viewed, or alcoholism specifically, can be viewed as a biological disease, no different from an allergy or any other kind of ailment. So even though it was a biological disease, though, AA basically posited that the only cure was a spiritual one by following the 12-step program to have a spiritual awakening, which they thought would basically help people overcome their addiction. Then after you've overcome your addiction, the idea is that you're in this stage called recovery, and that this is a lifelong process that keeps going. What's interesting to note about AA is that this is, like I said, kind of an initial attempt to treat addiction, but this did not actually come from systematic scientific research, right? The empirical basis for AA actually, and this is really considered important to its founding, was the lived experience of people who have actually struggled with alcohol use. And so there's this idea that in order to help other people struggling with addiction, that one actually needed to have that experience of overcoming addiction in oneself. And this was basically the beginning not only of addiction treatment, but of the emergence of what are called mutual aid groups, in which peers actually provide support to other people who may have been struggling with the same thing. And so after this, in this post-World War II period between about the 1950s and the 1970s, is when government agencies and academic researchers really started to take a scientific and systematic approach toward the study of addiction. So this began in the 1950s when there were a number of different research programs that were initiated on the behavioral and brain processes in addiction. A lot of these were started off in basically animal research and in behaviorism, which was a really popular framework in academic psychology at the time. Behaviorism is really focused on, well, behavior, right? So it's really focused on identifying reasons why individuals and other organisms tend to behave in a certain way. And it focuses a lot on reward and punishment. So which things are going to make a behavior more likely or less likely. And it became clear that a lot of aspects of addiction conformed to behavioral principles. And this really increased our understanding of how drugs not only impact different systems in the brain and neurotransmitters, but how behavioral processes lead to the emergence and the maintenance of addiction. In the 1970s, the National Institutes of Health founded two different sub-agencies. So this is NIAAA, which is the National Institute on Alcohol Abuse and Alcoholism, and NIDA, which is the National Institute on Drug Abuse. And these were the first federal agencies that were actually tasked specifically with funding academic research on alcohol and drug use disorders. As a result of this, we started learning a lot about the epidemiology of substance use. There were several different longitudinal studies that followed people over time to study how addiction emerged and how it progressed. And what this documented was that there were many different pathways that were in and out of addiction. And we started to learn a lot more about how people change, both in terms of becoming addicted to a substance and how people are able to overcome that. In 1970s, there was another big development that was kind of happening all over behavioral and brain sciences, which, like I said previously, had really focused on behavior. So as a result of reward and punishments, how can we actually change people's measurable behavior? Well, what the cognitive revolution really did is it made people think a lot more about these things that are intangible, that are really difficult to measure and study, but tend to be really, really important. So things like people's thoughts and their perceptions. So the study of substance use disorders, there's a lot of focus on perceptions of substance use, expectations about what use will do for someone, and motivation. And so as the science evolved, there were more and more attempts to try and integrate this cutting edge science into new addiction treatments. So new models of understanding of addiction included many different processes. So like I said, behavioral or learning models that focused on rewards and punishments and how this affected behavior. Models that emphasize the social context and the motivational context of addiction, and then models on cognitions related to addiction. What kind of thoughts and perceptions might actually be involved in substance use and in the maintenance of a substance use disorder? It also became clear that beyond the direct impact of drugs on the brain, so clearly drugs have very profound effects on human neurotransmitter systems, and this plays a big role in the maintenance of addiction. But a lot of this research demonstrated that, or there became this growing acknowledgement, right, that drug effects and responses also have a social, environmental, and personal context. You cannot get out of these contextual effects, right? So there might be certain social situations that someone might be more triggered to use in, certain environments that lead someone to have a substance use disorder. And in terms of personal context, there are all kinds of reasons that people can describe about why they might be using a substance. So treatments really incorporated a lot of this knowledge by including procedures that allow people to question their expectancies about the effects of drug use, identify triggers or contexts that encourage them to use and try and avoid or cope with those situations, increase readiness for behavior change. There's also a lot of research on stress and mood management, because we know that substance use does not exist in a vacuum, and that people who are struggling with a lot of negative emotions and difficult to manage emotions and stress might be more prone to use a substance as a way to potentially relieve that stress. So there's also a focus on how can we address that. And finally, things like social skills training, like teaching people how to refuse use in a group setting. And so throughout this process, a lot of different paradigms started to emerge, starting in the 1970s and 1980s. So things like harm reduction, relapse prevention, motivational interviewing, and cognitive behavioral therapy. So I'm going to go into more detail about what these different modalities of treatment are in a few minutes. But first, before I do that, what I want to point out is something that's been occurring throughout the emergence of these sort of research-based paradigms, and it's continuing on to today. And that's that there's been, especially, this is to some extent, I think, in all kind of mental health treatment, but maybe especially in substance use, there's been this historical tension between research-based treatments and traditional addiction treatment frameworks like Alcoholics Anonymous. And so many people who have lived through addiction, understandably, have grown to feel that lived experience in the process of actually having an addiction and overcoming an addiction yourself is really essential to helping others. This is kind of a founding tenet of peer support groups like Alcoholics Anonymous and Narcotics Anonymous, NA. And so sometimes this can cause people in the addiction recovery community to question treatments that are based on knowledge gained from the scientific method, which is arguably a lot more detached and less personal than lived experience. This is coupled with the fact that a lot of research and treatment that's conducted right now in this field are actually done by people who might not actually have personal experience in addiction. And so this has been an ongoing source of tension. So in terms of current behavioral addiction treatments, we like to think of this as a menu of different evidence-based treatment options. I'm going to talk about some of the primary ones that are used in practice today. So what do I mean when I say behavioral treatments? So behavioral treatments is basically an umbrella term for any type of therapy that's used to treat mental and behavioral health disorders, including substance use disorders. And so what these disorders typically involve is meeting with a treatment provider, basically in terms of individual or group therapy, and meeting with that provider for multiple sessions to help a person work towards change. So really the goal of these types of treatments is to help people identify potentially maladaptive or unhealthy patterns in their behavior and try and come up with strategies to change them. So it's really a kind of a collaborative focus on helping people gain knowledge about things about themselves they want to change and then helping them do it. So one of the evidence-based treatments that is very frequently used in treatment for addiction or substance use disorders, especially early on in the treatment process, is called motivational interviewing or motivational enhancement. And so people can often get stuck due to basically ambivalence about behavior change. And what I mean by that is there are a lot of cases in which someone is able to recognize that substance use is causing a lot of problems for them. And because of that, they might want to change their behavior. Yet at the same time, the substance can also be serving some functions for them that might make it scary or difficult for them to fully want to commit to changing. So you can think of an example. Somebody might, who has social anxiety, who doesn't like being in social situations, finds it uncomfortable, might find that they're able to cope with those situations better by using alcohol. So if alcohol starts causing problems in their life, they might want to change that, but then they might be kind of scared about, well, what is my life going to be like now if I don't use this substance? So things like this can lead people to feel ambivalent and basically flip back and forth from a day-to-day basis about whether or not they actually want to try to start addressing their use. So what motivational interviewing, or MI, is an approach to help people resolve ambivalence about treatment engagement and behavior change. And what it really boils down to is it's a collaborative and compassionate conversation with a person to try and assess how their current behaviors fit with their long-term goals and values. So you want to actually, this is sort of basically the opposite of what you would think of as an intervention, right? Where a professional goes to someone and they say, hey, I'm really concerned about this. You really should think of changing. The conversation is always centered on the patient. Basically, you're asking them about what their goals are, what things about their life that they wish they were different, and how substance use fits in with those things. And so the goal here is to build an intrinsic motivation in the person to actually resolve that ambivalence and work towards a change. So we want to encourage what we call change talk about ways in which you can change, reasons why you want to change, and help people further solidify their commitment to change. So typically this is actually a brief therapy that lasts only a few sessions, and it's actually often used as sort of an introduction and a preparation for additional treatment steps later on. And so one of the most common treatment frameworks that's used now, both in substance use disorders and in mental health care in general, is called cognitive behavioral therapy. So this is another umbrella term. So the CBT approach basically holds that psychological problems, including addiction, often stem from faulty cognitions about others, our world, and how we relate to it. And so this faulty thinking is basically consists of things like cognitive distortions and ways in which our brain kind of reliably processes information inaccurately. One of the best examples of this in substance use disorders that's been studied is something called expectancy effects. So especially in using certain drugs like nicotine, this seems to be really apparent, where if you actually ask somebody why they want to use a substance like nicotine, they might say that, well, it's because it's going to make me feel better. I expect this to, I'm kind of feeling down right now, and I expect this to make me feel happier, basically. And so this is something that a lot of people report. But when you actually measure people's mood after they've used the substance, oftentimes that expectancy is not actually true. So we would view this as a faulty cognition. It's something that is distorted, and something that if you help people work on addressing, they might be able to better recognize that the substance isn't actually serving the role that they think that it does. So this mode of therapy was really started or was based on basically foundational work by someone named Albert Ellis, who suggested that irrational thinking or biased thinking might result in a lot of different mental health problems. Aaron Beck is probably best known as a proponent of CBT, and he proposed what we call the cognitive triad, which is what I'm showing right here. And so the basic framework of this is that most psychological problems, including addiction, can be viewed through the lens of three different interrelated processes. So behavior, which is what we do, thoughts, which is what we think, and emotions, which is basically what we feel, and the physiological processes that are underlying that. The idea is that most of these problems, once we kind of characterize them, you can kind of intervene on all these different parts of the triangle. So like I said, if somebody has a faulty cognition about their expectancies for substance use, you can help them think about the evidence for that and maybe correct that cognition. For behaviors, you can identify certain situations in which someone might be tempted to use and kind of help them come up with a strategy for how to either avoid that situation or cope with it. So overall, the goal of CBT is to identify and correct maladaptive thought and behavioral patterns. Typically at the beginning, it involves helping somebody monitor their behavior. So monitor, for example, their substance use on a day-to-day basis and record the thoughts, feelings, and behaviors that go along with that. After that, we can help them identify whether there are, short and long-term positive and negative consequences of use, try and help them correct any kind of distortions they may have about those things, and to help them cope with or avoid situations in which they might be tempted to use. So one of the coolest things about CBT is that it is skills based. It is not necessarily just based on having the therapist help somebody through a current problem. It's really the goal of it is to help people learn skills so that they can be their own therapist. So when I'm doing an intervention like this, I'm usually saying that, kind of ironically, our job is really to make ourselves obsolete, is to give you the skills to work through these problems on your own and basically be your own therapist. And so the nice thing about this is that the skills that are learned in CBT tend to remain even after treatment and help people in the long term. Another treatment that is not necessarily widely available, but that there's been a lot of research on, is called contingency management. And so this treatment is basically as simple as providing tangible rewards that reinforce positive behaviors. In this case, it might be abstinence from substance use or attendance of substance use treatment. So there's two types of this. There's what are called voucher-based reinforcement symptoms, in which a patient might earn a voucher for a desired behavior. In the case of substance use disorders, for example, they can be given these rewards for having a clean urine screen, right, for instance, and then these rewards tend to increase over time with a longer period of sobriety. Instead of vouchers, there's also prize-based reinforcement systems where patients can receive physical prizes for a desired behavior, such as drawing something out of a fishbowl. And so, like I said, rewards tend to start small, and they tend to grow for longer streaks of positive behaviors. And it's important to know that this is a really useful tool for basically combining with other treatments in order to improve outcomes and retention. So if you're able to use this to help somebody basically stay abstinent from a substance for a certain period of time, then they might be better able to actually engage in treatment and move forward. So this really increases treatment retention and promotes abstinence. And it's worth noting that this is controversial, right? Some people have a very negative view of this treatment, but it's been found to be very effective at reducing use and preventing relapse. So in a lot of ways, the benefits of this type of treatment outweigh the perceived controversy. They're also mutual help groups. And so these are, like we talked about, Alcoholics Anonymous is probably the first example, and Narcotics Anonymous came afterwards with some very similar philosophies. The goal of these groups is really to support recovery from addictions by basically putting you in a community of people who have already overcome them and who are able to support you through that. So AA and NA are probably the most popular and widely known examples of this. There are also SMART recovery groups. So these are groups that have a little bit of a different philosophy from AA, that are less focused on spiritual awakening and more focused on some conceptualizations from current research on substance use. So they can be a good option for somebody who likes the community of AA, but might not necessarily embrace the philosophy of AA. All of these groups tend to be free of cost, and they tend to be widely available. So, we have them here in Ann Arbor. They're all over the country, and in many cases, probably all over the world. So they're a really great option for people to follow up with and get support. Now I'm going to talk about this concept that becomes really important in substance use disorder treatment, which is called level of care. And so the severity of addiction and relevant psychosocial factors are really important considerations when we as professionals are trying to help somebody find the right treatment, and also determining the level of care that they need. So level of care basically refers to the type and the intensity of treatment services. And the American Society of Addiction Medicine, or the ASAM, has this really nice helpful heuristic for basically viewing a level of care as a gradient, all the way from basically the lowest level of care to the highest. So on the low intensity wave at about 0.5, we have what are called early or preventative interventions. And these are basically interventions that are carried out before addiction even develops or becomes severe. So maybe somebody's from adolescent is from a high risk group that might be identified as somebody who is at a risk for a substance use disorder. They would be participate in a preventative intervention. So the idea is that you might be able to sort of prevent that before it even starts. Then as we move further along that gradient with the number one, we get to basically outpatient services. So this is typically weekly behavioral therapy, either in an individual or a group setting. At 2, this is basically intensive outpatient or partial hospitalization services. Intensive outpatient, or IOP, is a very common format for treating substance use disorders. And this is where somebody is coming in for treatment usually multiple times a week for several hours at a time. So it's often really used in the sort of acute or early recovery phase. And then as you keep going up, this moves up to residential services with or without medical management of addiction and withdrawal. This becomes necessary if a person is really having difficulty stopping on their own before they engage in some kind of therapy, or if they are in danger of potentially harmful withdrawal symptoms, right? So this is kind of the highest level of care that you would be able to refer someone to. Level of care is recommended based on a professional's multimodal assessment that's basically assesses several different dimensions in order to construct a treatment plan. So we want to consider what ASAM calls the 6 dimensions of multidimensional assessment. So we want to think about acute intoxication and withdrawal potential. So is somebody currently using, and if so, are they using in a way where they might actually have dangerous withdrawal symptoms? Are they going to be able to stop on their own? We also consider biomedical conditions and complications that might be relevant to substance use, as well as emotional, behavioral, or cognitive conditions that might cause complications. Along with this, we also really want to assess somebody's readiness for change. So this goes back to the concept of motivational interviewing or motivational enhancement. So how ambivalent is somebody? Are they really committed to change, or are they still kind of wavering? And this is a really important consideration when determining the appropriate level of care. And so how do we actually end up picking what option's best? Well, ideally, this is always going to occur as a collaborative decision-making process between the healthcare provider and the patient. So this is what I basically always try to do in this situation, is let the patient know that really they're the ones in the driver's seat here, right? We can make recommendations, we can talk to them about possible options, but ultimately it has to be their own decision and their own intrinsic motivation to participate in treatment. Because if somebody is not feeling like they want to follow through on a given treatment, they're probably not going to succeed at it. So this depends on basically the fit of the treatment, the level of care that might be needed, and what treatments are available. We would have an open discussion with the patient about these options to collaboratively come up with a plan. And sometimes I'll say that, because we, like a lot of things in healthcare, it's oftentimes hard to guess at the outset the exact kind of care that somebody might need. So this sometimes requires a trial and error process to figure out what works best. Maybe somebody starts off going to an IOP program, but it turns out they might not necessarily be ready yet, or at a readiness for change yet where they want to engage for that. In that case, we would recommend a different level of care. So this is a fairly common occurrence. All right, so now I want to talk specifically about the University of Michigan Addiction Treatment Services, or UMATS, which is our addiction-focused clinic here at U of M. So we provide outpatient addiction care for adults and adolescents. Basically, in terms of level of care, we usually go between outpatient therapy, so this ASAM level 1, all the way to intensive outpatient therapy at level 2.1. So we offer addiction assessment and consultations, which really consist of evaluating new patients and having that kind of collaborative discussion about what kind of treatment might be appropriate with them, kind of guiding them through that process. In terms of moving forward with actual treatment, we offer individual behavioral treatment, which consists of typically weekly or biweekly therapy with an individual therapist. Usually this is done with a cognitive behavioral therapy framework or motivational interviewing. We also offer several group therapies, and we can encourage people to participate in mutual help groups. So we are able to refer people to different resources in the community. We also offer medication evaluation and management, both for substance use disorders and other psychiatric disorders that might be playing a role in addiction. And we also have dual diagnosis treatment. So as I said before, we recognize that substance use does not always occur, and actually often doesn't occur in a vacuum. There's often comorbid conditions like anxiety, depression, ADHD, that might be in some way contributing to substance use disorders. And we are really dedicated to trying to figure out what those are and address those dual diagnoses. Who can come to UMATS? Well, UMATS basically welcomes all people who want to understand or to change their use of substances. So we see people as young as adolescents all the way through older adults. So basically the entire spectrum of the lifespan where people can be expected to have a substance use disorder. And we accept most major private insurances. We're located here at the Rachel Upjohn building. We offer both virtual and in-person treatment formats. In terms of the specific, in terms of the group treatment, which really is one of the main focuses of our clinic, group treatment is really helpful in treating addiction because really not only because of the efficiency of it, right? You're able to have one clinician work with several different people at a time, but it's also can be really helpful because people will tell us that they tend to find that being in a group where you're learning these kind of skills and learning these kinds of strategies can be helpful both for the support and also just having another set of minds there, right? Have been through very similar problems that can support you and that can help you think through how to apply the skills in your own life. And so we have an intensive outpatient program. For a while during the pandemic, this was virtual, but as of the past few months, our IOP has been in person. It meets 3 days a week for an hour and a half at a time, and it usually lasts about 4 weeks. We also have weekly groups. Typically, most of these are actually in a virtual format. So we have a cognitive behavioral therapy group, a discovery group, which is really helpful if somebody's still kind of in that stage where they're a little bit ambivalent about their use and they're trying to think about what kind of goals they have for their use. So it's really meant to help them kind of figure that out for themselves. We have groups to address dual diagnosis, early recovery support groups, and we also have some groups that are focused on adolescents. So now, I know you guys probably have a lot of questions at this point, but I just want to go through some frequently asked questions and answers. So probably the question that's most likely on everybody's mind is, does treatment work, right? And so it is heartening to know that there's been a lot of research on this, and sometimes people can think that addiction or substance use disorders, that the majority of people who have those disorders have trouble getting better. Basically, actually, that's really not true. The vast majority of people who have a substance use disorder will eventually recover. Oftentimes, and occasionally, this happens without any treatment at all. And so when you think about, does treatment work? Do all treatments work for all people? No, not necessarily, right? So because they had decades of research now looking at different types of treatments, it has come to light that there are certain treatments that might not be very effective or might even be harmful. So an example is basically treatments that are really focused on confrontation of a person, basically putting them on the spot and trying to convince them in a top-down manner to kind of change their behavior. Those treatments can actually cause harm in some ways. So do all treatments work for all people? Not necessarily, but do some types of treatment work? And do they work for most people? Absolutely. And one thing to note is that treatment always is going to work better if you're receiving it. So it's really important that if you start a treatment that you try to follow it through until the end. Continuing care is very, very important. Next question is treatment necessary? So as I said, the vast majority of people who have a substance use disorder are going to recover. Another really interesting statistic, though, is that the majority of people who have a substance use disorder out in the community actually do not receive treatment. So as a field, despite our efforts, we actually have not been that successful at giving people access to care that can help them in the substance use field. For a number of reasons, there's kind of ongoing stigma about substance use disorder, so people might not feel like they want to reach out. There's also limited resources in a lot of communities, and so unfortunately, a lot of people don't necessarily get treatment or get the most up-to-date treatment. That said, natural recovery is often possible. So people are able to, in a lot of cases, actually find strategies that work for them without necessarily seeing a professional. And this is certainly possible. But it's important to note that this becomes increasingly rare as the severity of the substance use disorder increases, right? So if somebody is at the stage where we might recommend residential treatment or where they're really having trouble stopping on their own, natural recovery becomes less and less possible. And it's important to try to get somebody resources at that point. Another thing to note is that residential treatment may not always be required. So there's been some studies that have found that it might in some cases not be more effective than just outpatient or intensive outpatient, but that it might be especially effective specifically for high severity patients. So that's why we want to be careful not only to think very carefully about what we're recommending, but we also want to think a lot about what I talked about before, the levels of care, what level of care is appropriate so that we can best distribute resources and best give people the help that they need at the appropriate level. There's some other questions. So one of them is, are there medications that can actually help treat addiction? Absolutely. And if you're curious about that, I really encourage you to come to the next session on January 11th, where our colleague, Dr. Cam Coleman, is going to be talking specifically about medication treatment options. So specifically, there's a lot of really good options for specific substances like opioids and alcohol use. And it'll be really exciting to learn more from him next session about these. And finally, a question is, are some people better fit with specific types of treatment? And that's a complicated question. The answer is that we really need more research, and this is one of the ways in which our knowledge really could be improved. Anecdotally, I can't necessarily say that different specific treatments fit, or specific treatments fit or are more effective with specific people. But when it comes to people's preferences, there's definitely examples in which people find a treatment to be more palatable and to kind of find different types of treatment more engaging. So one example of this is sometimes you'll have people who really, really like the community that Alcoholics Anonymous provides and that kind of peer support framework, but they might not fully embrace the philosophy of AA. And in that case, they might be better off attending a different group. So we need to learn more, but this definitely could be an issue in a specific case. All right, so as I said, that's the end of my talk today, but on January 11th, Dr. George Cameron Coleman is going to be presenting specifically on addiction medications for relapse prevention. So if you're curious about medications and basically the whole process of using medications to address substance use disorder, I really encourage you to attend that session. Dr. Ann Fernandez, her colleague, is going to be moderating that. All right, and so thank you very much for your time and attention, and I'm really excited to start answering your questions.
I think I was muted there as I was talking. Sorry. So thank you for the presentation. And we've got good questions coming in. And I'd encourage people to put their questions in the Q&A, and we'll do our best to get through them all. So as a first question, they're wondering how long someone needs to attend treatment in order to have a good foundation or to have good outcomes. Oop, now you're muted, Alex. Sorry, we're trading off.
Sorry about that. So it really can vary. It depends a lot on the person's specific substance use disorder, and it also depends a lot on level of care. So residential treatment programs can often last between 1 and 2 weeks and even 30 days or more, depending on the severity of withdrawal symptoms and the severity of the use disorder, right? Typically, residential treatment is followed by intensive outpatient treatment, which doesn't, so IOP can be used in and of itself, depending on the level of care that's appropriate, or as a follow-up to residential treatment. And IOP itself typically takes about a month. So our program at UMATS is 4 weeks long for most patients. And then when you think about going lower on that level of care spectrum, right, outpatient therapy, there can be a lot of variability in that as well. So basically, a lot of the therapies that we tend to use currently are designed to be short-term and problem-focused therapy. So what does that mean? Like I said, with CBT, they're often focused on helping people learn skills that they can apply in a lot of different parts of their life and that they can keep with them when they finish treatment. And so they're really meant to be fairly short term, like say 12 to 16 sessions. That said, because we know that a lot of people are different, there might be specific comorbidities, anxiety, depression, other factors that people might need to address. And there also, can be some bumps in the road in recovery from addiction, right? So that people can get better for a while and then relapse. And that's okay because, the treatment can be adapted sort of as these things come up. So typically, even outpatient therapies tend to be short term in the matter of months, but it really depends on basically how things go and whether or not we would want to circle back with somebody.
Great, thank you. And question here is, what do you mean when you say most people recover? Does that mean that someone has complete sobriety, reduced level of use, or something else? And I think that question came in as you were talking about kind of the natural recovery phenomenon.
That's a great question, because it gets at a question that I didn't really address, but that's really, really important here, which is basically, how do we define addiction? How do we define recovery from addiction? So when I say most people recover, I'm referring specifically to the technical definition of a substance use disorder. And so somebody can, in theory, use substances or even actually use a substance quite a lot without necessarily meeting criteria for a disorder. So criteria for a substance use disorder, it's defined by the Diagnostic and Statistical Manual for Psychiatric Disorders, which is basically what we use to determine whether treatment might be appropriate and which treatment might be appropriate when we're dealing with addiction, but also other mental health disorders. And basically, the diagnostic criteria are not necessarily about the amount of a substance that someone used. They're really focused on what problems does somebody have because of the substance. So is it actually causing dysfunction? Is it actually causing significant problems or significant impairment in their life? And so when I'm talking about recovery, I basically mean that somebody, whether they completely stop using a given substance or whether they just kind of return to using a low level of a substance or just change their relationship with that substance where it's no longer interfering with their life. That's how we broadly, in a scientific sense, define recovery, is basically the absence of the disorder. And this could be a controversial thing, right? Because I think there's a lot, for example, in the AA philosophy, there's a real emphasis on complete abstinence. And understandably, I think a lot of people will view complete abstinence as the goal. And that often is the goal for a lot of people, because if somebody recognizes that, hey, I have a problem with this, I just really have trouble controlling it, even if I try to use just a little bit, then their individual goal might be to be completely abstinent. But I will say there are a lot of cases in which somebody either doesn't necessarily want to or doesn't end up completely stopping the use of the problematic substance, or maybe just doesn't stop using other substances, in which they can still recover, in the sense that even if they're using the substance to some extent, it is not interfering with their life and it's not causing with impairment. So there's definitely a lot of cases like that as well.
Great, that's really helpful. And one of the questions relates to something you touched on, and that's that there's a fair amount of overlap between mental health problems and addiction, and those sometimes go hand in hand. And what do you treat first? If someone has, let's say, depression and a substance use disorder, when they come in, how do you know where to start?
Yeah, No, that's an excellent question. And what it really, what it really is based on is the severity of the use disorder, right? Because if somebody has a substance use disorder where, they're able to, they're not impaired a lot of the time, right? Necessarily, they're not necessarily using constantly or using when they're going to go to a session, right? It's very possible that you can address the mental health disorder concurrently with the substance use disorder, or even first, right? Because sometimes the mental health disorder is kind of a driving factor in the substance use disorder. However, the consideration as somebody's use disorder gets more and more severe, the consideration becomes, can I actually effectively treat the mental health issue given this person's level of use? So if somebody is using constantly every day, they're not able to come to therapy sober, or maybe they're able to come to therapy sober, but they're not able to kind of engage in the therapeutic activities that we talk about in therapy on their own time because they're using the substance so much, right? Then it really becomes a question of, how can we get them to a level of care of substance use disorder treatment so that we can then, once they have a period of abstinence, engage in more therapy, right? And actually, this is something that we relate to the last question, right? It may well be that somebody doesn't necessarily want to stop using a substance, or maybe their disorder isn't that severe, that complete abstinence is really the answer at the moment. We tend to recommend to people, though, if they're hoping to address use and if they're hoping to address mental health disorders as well, that they have what we would call an abstinence trial, right? That they would just, at least temporarily, take a little bit of time off of the substance, because this can make it easier to both help somebody learn how to kind of cope with a mental health problem without a substance, right? And also kind of just be a little bit clearer headed in some ways, right? To kind of engage in the work that they're going to do to try and address the mental health. So it's person specific, but sometimes you have to address the use disorder first, and it really depends on severity.
That makes sense. And there's several questions coming in anonymously about, how do you work with a loved one or someone you care about who may not realize that they need to change their substance use? So how can you help convince someone to go into treatment? And you mentioned the term interventions, and maybe those aren't really evidence-based, but what does work? How do you confront or help someone see that it's time to change their substance?
Yeah, so this is such a difficult situation to be in, right? Where you really can see that someone's use is causing a lot of problems for them, might be causing a lot of problems for your family, and you really want to intervene. So like I said, it's media might have you believe that having an intervention where you basically, kind of a classic intervention like you would see on TV, where you gather somebody's friends and family and really put them on the spot and say, look, we're really concerned about your use. We really think you need to stop now. It might, based on media portrayals, that might actually seem like that's an effective way to get someone to motivate someone to change their behavior. Oftentimes that really couldn't be further from the truth. So one of the observations that led to the founding of motivational interviewing as a treatment modality is that somebody is much more likely to be motivated to change their behavior if they can come up with the reasons themselves, if they build intrinsic motivation to do it. And in fact, it's just kind of an interesting observation that's been borne out by research, which is that people are actually less likely to want to do that if they feel like they're being coerced in some way, right? Or that somebody is sort of forcing them to do something. So that is just something that I think I would keep in mind when you have that conversation with a loved one. So I think that a couple of elements are important. One of them is that it's in a space where the person feels comfortable, right? So they might not feel comfortable in front of a big group of friends and family. They might feel comfortable if it's just kind of you in a nice private setting that they're used to, right? Reaching out and having an open and honest conversation about their use. So you can ask them about it, say, hey, I noticed that, you might be struggling in some way. Do you want to talk about it? Are you having some problems? Kind of make it an open discussion. You can share your concerns, especially if the person, you feel like they might not have a lot of insight into the problems, but it's important that you try and do that in sort of as empathetic a way as possible. And that can be really hard, right? Because you're concerned, right? Like you might be really anxious about this. about this problem, and you really want to fix it. But everything that you can do to just kind of to be supportive, to be open, to not be coercive, and just kind of let the person there that you're noted that you're there to support them and that you can help them if they want, it is going to be the most productive way to address that. It's easier said than done, but just keep it in mind. Keep it in mind that element of it's really about kind of building somebody's own intrinsic motivation to engage in treatment rather than necessarily forcing them.
Well, thanks. It's a very difficult position to be in, and can feel like a lose-lose situation, or like they're not very good options. And so it's very, very difficult. What about if someone is engaged in care for another mental health condition? So for example, depression. Do they need to see someone different for a substance use disorder, or can they continue with the therapist they're already seeing? How do you think about care with someone who's already engaged in another type of mental health care?
Yeah. So I think it it really depends on if you're in that situation. It really depends on your current provider's level of comfort and with substance use disorders and willingness, right? So if they have some experience in treating substance use disorders and feel kind of ready and willing to address that with you, then that might be a good option. In general, though, what often happens is if somebody has been working with a patient for a while, is they might refer them to a place like UMATS to basically get an evaluation from another party that has expertise in substance use disorders and might be able to make some recommendations. So, in general, this is something to have a conversation with with the person that you're currently seeing if you're in a situation like that. But it can also really help to kind of get another opinion and get work collaboratively with the clinician who's trained in addiction to try and see if there might be other options available. So it's really person and case specific.
Great, and I'm going to paraphrase this question, and if whoever sent it can let me know whether I've not described it correctly. But you mentioned that there's been some work comparing inpatient to outpatient treatment, and outpatient treatment in many cases can be as beneficial or as useful as inpatient treatment. But how do you know where to start if you're not a treatment provider, but you're thinking about someone you care about or yourself? How do you find the right outpatient treatment, and how do you know if you're one of those people that might benefit from one type of care versus another?
Yeah. No, that's a great question. I'm sure it's a lot of it's sure it's something that it's that somebody who's getting involved in addiction treatment might wonder. And I think I'll address the last question first, which is that we really don't know. There's been some attempts to try and build models or trying to identify features of individual people that might indicate that they might benefit from a given treatment more than others, but we really just don't know a lot about that now. What I'm really excited about, both in my own research and in our field in general, is that there's been a really big effort to try and use predictive modeling, basically machine learning methods that are used to actually predict outcomes to try and identify features of people that might actually indicate that they would benefit from either a certain intervention or a prevention effort. But we're not there yet. So in terms of what happens now, like I said, oftentimes, unfortunately, this is a trial and error process. But I think the important thing in terms of thinking about what level of care to go to, what options might work, is that it's going to be helpful to talk to a treatment provider about it who's willing to have this as a collaborative discussion, right? So it's true that everybody's got different experiences, everybody's got different preferences for the treatments that they use and that they recommend, but ideally it would be your provider should have just an open and honest discussion with you about what the pros and cons of different treatments are. So for example, at UMATS, I mean, I think we often will use CBT focused interventions or motivational interviewing, but we have clinicians who have a wide breadth of experience in different therapeutic modalities, right? So how we handle that kind of thing at our clinic is, if I'm doing a new patient evaluation and working with somebody on treatment planning, I'll say, well, this is the kind of thing that we typically offer, but here's kind of the menu, right? So we like to give people the menu. And I think the question is a good one because you're right that it's really hard for you to know. The good news about this though is that is that, like we said, for better or worse, this is often a trial and error process. And just because you start one treatment, it doesn't necessarily you need to continue to that. So I guess that's the one thing I would say is, as a patient, if you end up going somewhere or starting on a given treatment and it just doesn't feel right to you, the most important thing you can do is speak up. And so we as providers really, really appreciate that, right? Because we can be wrong and we don't know how you're feeling, right? And so if something doesn't feel right and you want to try something else, I mean, the best thing that you can do is just to speak up about it and let us know. Because you're, like I said, you're in the driver's seat here, and it's not going to help anybody if you don't feel like this is the right approach for you.
No, I think it's a great point. And in the general community, there's perception of what rehab is, and I think it's usually envisioned as residential care and having a very consistent feel from one place to another. And it's probably the case that it couldn't be further from the truth. So for many people, or most people now, it's outpatient care, and there are a lot of opportunities along the way to make decisions, to modify care and try to make it fit better for people so that they don't have to feel like they choose between treatment where they have no control and they're in this environment away from home and being out of treatment. We hopefully can bridge that gap.
Absolutely.
Well, thank you so much for the presentation. We are actually coming up on the 8 o'clock hour here in Michigan. And for those of you in attendance, we hope that you found the information helpful. And you'll see that there are a number of links in the chat, and that includes our resource page for our clinic and ways of contacting us. You also are encouraged to attend the next presentation, as Alex mentioned, which will be on the 14th of December at the same time from 7 to 8. And I want to make sure before we close that I thank and acknowledge the support of the Patrick Gibbons Memorial Fund. You'll see the picture of Pat Gibbons on the screen and a little bit of a biography about him. And he's someone that played an enormous role in the community in Ann Arbor, both the treatment providers and the broader recovery community, and really supporting people in making changes in their substance use and making changes in their lives. So we really support we appreciate his support for this seminar and his work more broadly. So thanks again to Dr. Weigart, and thank you everyone for attending, and we hope to see you again in about a month. Take care.
Thanks, everyone.